Hey everybody, and welcome back to another video here at Whiteboard Medicine. We appreciate you checking it out. Today we're going to talk about sepsis, kind of basic concepts as related to sepsis. This is a very common thing that affects millions of people worldwide and unfortunately has a high degree of morbidity and mortality with it. So today we're going to dive into all things sepsis. We'll talk about the numbers a little bit, how much it costs, how many people get it, how many people unfortunately die from it. We'll dive into what it is, what it causes, symptoms, pathophysiology, how to manage it, and all that good stuff. So please stick around. This is going to be one video and probably a series we come out with that is kind of all about sepsis. So definitely subscribe, hit the bell button if this is an interesting topic to you. Quick 30-second break for introduction. Don't go anywhere. We'll be right back. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.
All right, thanks for sticking around. So sepsis basic concepts. Well, to establish why sepsis is important, we wanted to include kind of some of the numbers here because they are quite staggering, right? Many people watching this video maybe had sepsis, know someone with sepsis, or maybe you're in the medical profession and you provide care for patients with sepsis. I know in my day-to-day, I see patients with sepsis, severe sepsis, septic shock pretty much every single day I'm at work. And that is because this affects 50 million people per year worldwide. And of those 50 million people, about 11 million of them worldwide die. If we focus on the USA, just because that's where we live, that's 1.7 million people in the USA. And these are probably old numbers. It's probably even a little bit more. So multi-millions of people every single year are hospitalized with sepsis. Apologies, let us mute that. In addition to that, of every 1,000 people hospitalized, about 15 of them actually will develop sepsis during their hospitalization, right? So about 15 will develop sepsis during their hospitalization. The vast majority of people who present with sepsis, but you are at risk of developing it while in the hospital because obviously the hospital, as much as we try to keep it as clean and sterile as we can, certainly has infections that can spread within the hospital itself. In 2022, there was $62 billion worth of sepsis-related care costs. And that was in 2022, so it's most likely higher now. So as you can see just from these brief numbers, right, it affects tons of people. Unfortunately, many people die from it. If you're hospitalized for something else, you have a risk of developing it while you're hospitalized, and then it costs billions and billions and billions of dollars every single year. So what exactly is it? What is sepsis? Well, really it's a dysregulated host immune response to an infection. So just briefly, we're going to dive into a little kind of immunology. When you have an infection, you have bacteria, which are going to be these little yellow guys that invade maybe your skin and cause cellulitis, or maybe they get in your lung and cause pneumonia, or they get in your bladder and cause a urinary tract infection. The way we fight those bacteria off, and it happens with viruses, fungi, parasites as well, the way we fight those bacteria off is with our immune system. Our immune system is literally made of cells that are programmed to attack and eliminate invading organisms. And that immune response actually starts with what we call the innate immune response. Those are kind of the first responders. And then after that, later on, the adaptive immune response. And we're not going to kind of dive too much into the nitty-gritty details, but as part of the innate immune response, there's kind of two major cells. There's many, many more cells involved, but the two major ones we think about are neutrophils and macrophages. And that's what we drew here in the green and the blue, a neutrophil and a macrophage. And what happens is these two cells, when they detect invading organisms like bacteria, is they find those bacteria and they kind of take it into their cell, right? And when they take it into their cell, it prompts them to start releasing a bunch of these kind of inflammatory mediators. So they release it kind of out into the tissue, and you get all these inflammatory mediators. Neutrophils do the same thing, right? And I'm underselling some of the complexity of this, but these inflammatory mediators do a couple of things. One, sometimes they're directly toxic to the invaders, right? Sometimes they directly kill the bacteria. They also recruit additional immune cells to come help them fight the invaders. Okay, another thing they do is they then kind of present parts of the invading organisms on the surface of their cell. And what those do is then they start to activate the adaptive immune response. And the adaptive immune response has some of the cells you might recognize more. T cells are a big one, and there's multiple types of T cells. B cells, which secrete antibodies, right? Antibodies people have probably heard of. And when you get vaccinated, kind of antibodies are what help protect you from infection later on, or if you've been infected with an organism, the antibodies keep circulating, protect you later on. So the innate immune response, it triggers the adaptive immune response, but it also locally causes more immune cells to come into that area to fight the invaders. It secretes these kind of cytokine mediators. Some of them are directly toxic to the bacteria. Some of them cause kind of this inflammation in the area. But in a normal immune response, right, because just because you have an infection doesn't mean that you're septic or develop sepsis. Sepsis only happens to a small subset of those with infections, because usually what happens, in normal, which we'll say is no sepsis, this is just kind of the normal fighting off an infection, is those anti-inflammatory mediators or signaling molecules are balanced with the pro-inflammatory mediators, because these immune cells, they secrete anti-inflammatory mediators as well as pro-inflammatory mediators, right? Because you need pro-inflammatory mediators to help fight off the infection, but you also want to balance that out. So these usually balance each other out in a sense, so that this kind of immune response doesn't run rampant and run wild. Also, in the normal response, you usually have some degree of locally controlled spread of these mediators. So right here we have a blood vessel, just call it a arterial. And what happens is some of these inflammatory mediators do kind of end up in the blood vessels circulating around, but the vast majority of them stay localized in the region of the infection, right? So there's some local control of the spread of these inflammatory mediators. In addition to that, these bacteria are going to prompt an immune response no matter where they are. So there's also phagocytosis, which is when the cells kind of envelope these bacteria, take them into the cell itself. There's a degree of phagocytosis of bacterial debris and the bacteria themselves, because the more bacteria that spread, if these bacteria or even debris were to get into the bloodstream, they'd spread to a bunch of different tissues and then prompt this crazy immune response. So there's some local control of that infection in that area. But what happens when this gets dysregulated, right? And dysregulation leads to sepsis. It's your own immune system that's becoming dysregulated. So what happens when there's dysregulation? Well, those pro-inflammatory cytokines and signaling molecules start to become kind of greater than the anti-inflammatory, and that leads to a higher kind of spiral of inflammation. In addition to that, the bacteria or even toxins the bacteria secrete start to spread, right? They start to kind of spread out of that local area. More of them will get into the bloodstream and travel to different spots, especially toxins that the bacteria secrete. In addition to that, there's some that feel that there's a genetic predisposition to sepsis, that there's something in people's genes that cause them to be higher risk for sepsis, probably something that affects their immune system. So sepsis is when you have an infection, but instead of having this normal response where your anti-inflammatory mediators equal your pro-inflammatory mediators, you kind of have some degree of local control over the spread of infection, you're getting rid of the bacteria and bacterial debris, you start to get this dysregulation where your immune system kind of goes into overdrive, it runs wild, and the pro-inflammatory molecules signal much more than the anti-inflammatory, which then recruits more immune cells, causing more inflammation, and you kind of see how that spiral starts to develop, and bacteria can spread into the blood or into other areas that causes then a more widespread inflammatory response, and certain people's genetic makeup might put them more at risk for this, but that's still kind of something being studied, which is why we put that question mark here. So sepsis is when you have an infection and then you get this, your own immune system kind of goes into overdrive, and your own immune system starts causing damage to your own tissues or organs, right? So what does sepsis cause? Well, it causes exactly what we talked about, a dysregulated immune response that then can lead to tissue damage, because all these inflammatory mediators, all these things that are meant to kill the bacteria, can also injure your cells. And when that is just localized to where the infection is, that damage is mediated, right? It's moderated. It's not allowed to kind of spread or run wild. But when you are septic, it starts to spread and run wild, and you get more tissue damage. And if that progresses, it can lead to organ damage, organ failure. It can lead to shock, where your blood pressure drops, and that can honestly eventually lead to death, which is why we kind of talked about that, the morbidity and mortality, right? Morbidity being you don't die from the disease, but you have some long-standing chronic problems from the disease, and mortality being you die from the disease. That's why these with sepsis can be so high, because when this starts to spiral out of control, you get organ damage, organ failure, shock, death. And that's kind of septic shock or severe sepsis, we often call it. So beyond that, when you are septic, when you have an infection and your immune system starts to kind of run rampant, what symptoms can you expect? Well, this is tough because it's highly variable and there's lots of overlap with these symptoms and just normal things, right? Let's say you have the flu, but you're not septic. You still might get fevers and chills and rigors. You might have a little bit of elevated heart rate, but that doesn't necessarily mean you're septic. It could though, right? And the things we most often see quoted are fevers, chills, rigors, which is where you're really kind of uncontrollably shaking, confusion or altered mental status, shortness of breath or breathing more quickly or labored breathing, an elevated heart rate. All these can imply that you're septic. And there's overlap depending on where your infection is, right? If you have pneumonia, you might have shortness of breath even if you're not septic. If you have meningitis, you might have confusion. Meningitis is an infection of the meninges that cover the brain, even though you're not septic. But when these all start to stack together, right? Let's say you have a bad skin infection or a bad urinary tract infection, and you start to get these other symptoms, you really should be worried that you could be developing sepsis. And again, if this progresses, right? If this progresses untreated and you're going into that severe sepsis where you start to get organ injury or septic shock, then you can start to get low blood pressure, hypotension, a weak pulse, and it can even lead to cardiac arrest if it spirals out of control and you get really, really sick. So the symptoms are variable and there's lots of overlap with other conditions, but if you start to get this kind of conglomeration of symptoms, you should definitely be worried and consider going to the hospital. And this is when we see patients that come into the hospital and they start to share some of these things, that they have a urinary tract infection. Maybe we detected it on a urinalysis, but they also have some confusion and some rigors and they're a little tachycardic. That's when we start to work patients up and diagnose them with sepsis, which we'll get into a little bit later. But these are the symptoms to keep an eye on, both as a patient and those that work in the medical profession of, all different areas in medicine, because you might come to the emergency department with sepsis. You might be admitted to the hospital for a heart attack, and then you're on the floor and you end up developing sepsis. You could be in the intensive care unit in septic shock, critically ill, something that we see in our day-to-day jobs. So these symptoms are important for everybody to be aware of. All right, the pathophysiology, and remember, this is the basics of pathophysiology. Pathophysiology is like, what is the actual kind of thing going on in the body, right? And we put 3 different pictures here. This here is a cell. This here is a liver, but we're kind of using it as an organ. And then this here is a heart, which we're kind of using for the circulatory system. We started smallest to largest, because at the smallest level, you start to get tissue damage and cell death, right? That's what's happening in sepsis. That immune system response has become so dysregulated, and you have so many inflammatory mediators that are causing your cells to die, right? Apoptosis is when the cell, it dies. It kind of, quote unquote, commits suicide. It kills itself. And that is, the immune system can signal those cells to commit apoptosis. It's meant to be a means to protect other cells. Let's say a cell has an infection or is struggling with that. If that cell commits apoptosis, or kind of kills itself, that infection might die with it. Autophagy, which is where the cell kind of eats itself. And then direct cytopathic being like a direct cell toxic mediators come out of the immune system. So those neutrophils, those macrophages, they signal cells to commit apoptosis. They signal cells to eat themselves and eat others. And then some of the mediators they secrete are directly toxic to cells, because bacteria at the end of the day are cell too. So the molecules that can kill those bacteria also can kill some of our own cells. So at the cellular level, we start to get cell death. When we start to get more and more cell death, it can lead to tissue injury and death. Our tissues at the end of the day are made up of cells, right? So if enough cells die or enough cells are injured, we can start to get some tissue injury. And this can result in organ failure, right? It can affect our liver. It can affect our lungs. It can affect our kidneys. We see patients in the hospital with acute kidney injury from sepsis very frequently, or hypoxia, respiratory failure from sepsis, or liver injury, transaminitis from sepsis. It can even affect our brain. That's why confusion is something we sometimes see, right? Lung shortness of breath is sometimes something we see. And this can lead to, at the worst, multi-organ failure, MOF, multi-organ failure, okay? And if this keeps progressing, that's where we start to get the circulatory dysfunction. It can even cause circulatory collapse, right? We start to get vasodilation of the blood vessels, or the blood vessels start to dilate. And that happens from some of those inflammatory mediators, but also there's endothelial injury. The endothelium are the cells that line the blood vessel, and those start to get injured. We start to get microcirculatory dysfunction because the capillaries, right? We have arteries that go into smaller arterioles that go into capillaries and go into venules and veins. And we often think about kind of the arteries and things, but the capillaries, the smallest area, this is where you actually are getting blood flow to the tissues. These capillaries are where the kind of good stuff from the blood vessels comes out into the tissues, and the bad stuff from the tissues goes into the blood vessels, right? And it goes from arteries to arterioles to capillaries to veins and then back up to the heart and lungs. So you start to get microcirculatory dysfunction, or dysfunction at this capillary level. And all of this can lead to that severe sepsis or septic shock, which can lead to morbidity and even death. So this is a pathophysiology, starting with cell damage, progressing to tissue injury, tissue death, organ injury, organ failure, circulatory dysfunction, and circulatory collapse, right? There's this spiral that can occur if we don't intervene. So if we're thinking about that, how do we manage it? And this is, again, just basics. Each one of these things could be its own 4-hour video. But for the basics, how do we manage it? Well, the first way to manage it is to diagnose it, right? How do we diagnose sepsis? Well, this is best done at the hospital. Whether that's with your primary doctor in the emergency department or what have you. And when we think about sepsis as a physician or anyone working in the medical world, any of that care team, whether it's a nurse or med student or resident or intern or physician assistant or nurse practitioner, respiratory therapist or medical tech or assistant or anyone that I forgot, definitely give yourself a shout out in the comments, and I will apologize for forgetting you briefly. But all of us are constantly thinking about this. All over emergency departments, there's kind of think sepsis plaques and things, because time to diagnosis is related to time to treatment, and time to treatment affects morbidity, mortality, right? Faster intervention equals better outcomes. So we have kind of this high index of suspicion for patients with sepsis, because as we said up here, symptoms are very nonspecific. So it's really tough to diagnose. And if we miss it, it can lead to much worse outcomes. So sometimes what we think about is SIRS criteria. SIRS stands for systemic, hopefully I don't forget what it stands for, inflammatory response syndrome. All right. And the SIRS criteria are the several different markers that can hint that someone might be developing sepsis. And those markers include an elevated heart rate, okay, an elevated or a low body temperature, an elevated or a low white blood cell count. Those white blood cells are your immune cells, and an elevated respiratory rate. And I am not going to write the actual numbers because we certainly could look those up and I might get them wrong. But high heart rate, high respiratory rate, high or low temperature, high or low white blood cell count. And if you have kind of 2 of 4 of these, this implies that you're kind of positive for SIRS. And this starts to make us worried that there could be sepsis. Now, this is very non-specific, and it's meant to be, because we want to cast a huge net, and bring everybody in who could possibly have sepsis, and then we can eliminate people who don't once we've kind of thought about it, but we don't want to miss people. So this is not specific. If I, ran right now halfway around my yard or something, I'd probably have a high heart rate and a high respiratory rate. That's 2 of 4 of these, but I certainly am not septic, right? Because the other part of this is you have to have an infection. So if someone comes in and they have dysuria or burning when they urinate, some suprapubic pressure, pressure where their bladder is, you get a urinalysis. The urinalysis is positive or concerning for infection, and they have a heart rate, that's elevated at 110, and their white blood cell count is elevated at 14, right? These are 2 SIRS criteria plus infection, and this would be a patient that we were worried about sepsis. All right. And when we get worried about sepsis, then we start to wonder, is there severe sepsis? Okay. or septic shock. And some of this verbiage is simply just verbiage, and it does change when kind of organizations come together with different guidelines. But severe sepsis is usually when there's some organ damage or indication that the tissues damage, I don't know why I put it in there, tissues are not getting enough blood flow. And this is things for people who work in medicine, like acute kidney injury, acute liver injury, an elevated lactic acidosis, coagulopathy is another one where your blood is not clotting appropriately. And then septic shock is when this has progressed to hypotension or low blood pressure, okay, or kind of severe organ malperfusion. And if you're septic, you certainly should be making sure a patient is not having severe sepsis or septic shock, right? So hopefully that makes sense for how to diagnose it. You have to cast a wide net, high index of suspicion, and really make sure you're thinking about this in patients who are presenting with some of these nonspecific complaints. Treatment for this is really treating the underlying infection. This is critically important. Time to antibiotics if it's a bacterial infection, which it most often is, right? Antibiotics don't work for viruses, they don't work for fungi, they don't work for parasites. So if you have influenza, if you have the flu, antibiotics will do nothing but harm you. But if you have a bacterial infection causing sepsis, it is really important that we treat the underlying cause as quickly as we can, because time to antibiotics is important. The sooner we start treating that infection, the better that patient is the potential to do. Okay, so this is a matter of either starting broad spectrum antibiotics, or if you already have a source, let's say you have a urinalysis that's already positive, focusing on that genitourinary tract, and antibiotics most effective for that. Then the other thing is related to diagnosis, because part of treatment is identifying and then intervening if a patient has severe sepsis or septic shock, right? That organ damage or kind of that circulatory collapse that can happen. And then the treatment for this does involve, there's, certainly debate always on some of the complexities of this, but involves intravenous fluids, right? IV fluids. It involves kind of monitoring organ function. We'll say monitoring organs. It involves, again, antibiotics, time to antibiotics. And then it involves trying to detect the exact cause of infection, the exact bacteria. With blood cultures and, if it's a pneumonia, x-ray of the chest, if it's an infection in the urine, sending the urine for a culture, et cetera, et cetera. So doing a little more hunting for the cause of infection. All right, that is all we have for you today. That's kind of the basics, the introduction of sepsis. Certainly let us know what thoughts, comments, questions you have down below. We're going to get into some of the nitty gritty of this in future videos, so subscribe, hit the bell button, all that good stuff. Share any stories you might have if you've treated patients with sepsis, or if you've had sepsis or know someone with sepsis. We'd love to kind of hear some of your stories in the comments too. We also want to give a shout out to our Patreon page, where we're starting to work hard to ramp that up with study outlines based on the videos, practice questions, all that good stuff. Certainly the more support we get, the more time we'll have to dedicate to that. So definitely if you're able and interested, check out that Patreon page. It's linked in the video description. No further ado, we appreciate y'all. Stay well, keep learning, and we'll see you next time.